All right, so macrolides is our next set of antibiotics. So in this one, we're going to have treatment for Legionnaire's disease, pertussis, diphtheria, pneumonia strep pyogenes. Again, hitting a lot of these gram-positive bacteria. Let's talk a little bit more about our macrolides. So probably the most famous macrolide in this category is something called erythromycin. These can be bacteriostatic for the most part, but if we increase the dosages, we can really get some bactericidal activity out of them. They are both positive for both positive and negative bacteria. Like the higher we go, the more effectiveness we get with those. If the patient's allergic to the penicillin, we can try these. And of course, always looking out for our patients to make sure they don't have any liver or renal issues, because we don't want that to become an issue if we start giving these medications. We want to watch out for those liver and renal side effects. Probably the most famous one out of here, erythromycin is a pretty old drug now. I had a physician the other day that wanted to prescribe it, and then whenever we got the price listing on it, it was around $400 to $500. Erythromycin's really not prescribed that much anymore, but azithromycin, we see that still quite a bit in the world. Typically these patients, respiratory infections, different things like that, we give this one for. It became a very popular one. I will tell you that a part of this medicine has fallen out of favor just because it's been used so much that we do see a little bit antibiotic resistance. So probably like in the last 3 years or so, I see a little bit less azithromycin. Again, sometimes the medications just work. This medication for the sinus infections, those sort of things just works better. So I always ask my patient, what antibiotics have you been on in the last 90 days? And then not repeating that same class over again. The side effects for our macrolides are pretty much the same like we've seen in some other places. One of the things that can happen with this one is something called QT prolongation. So when we're looking at someone's heart rhythm on an EKG strip, the space between the Q and the T is a measurement, a certain measurement. Well, what happens with QT prolongation is that eventually that QT spreads out farther and farther and farther and farther apart, and then boom, the patient's heart just stops. That's called QT prolongation and results in a sudden cardiac death. We don't want sudden cardiac death in any patient, so we're always on the lookout for that in case these patients are getting the extra high doses in the hospital. There's actually several antibiotics. This one and the fluoroquinolones that are pretty much known for doing that are causing that QT prolongation. So if you hear about someone having sudden cardiac death after taking an antibiotic, it may be because of QT prolongation. So any patient has a cardiac history, I always want to think about those patients. I want to think about what's going on with our other medications before we start to administer these. These medications, these right here, these are like the kids on the playground that don't want to play with anybody else. Anytime you hear the medicine, carbenzapine, theophylline, cyclosporin, warfarin, verapamil, diltalazine, any of the HIV drugs, specifically the protease inhibitors, they just don't play well with hardly anyone. And so because of that, we tend to not want to pile a whole bunch of drugs on these patients because they just don't, the medications aren't as effective because they don't play well. They don't mix well at all. So be careful whenever you see these names come up on someone's drug list, that we're checking to make sure that we're not having contraindications, that we're not having ineffective results because of these medications. With this medication, the macrolides, we typically can give them with food. That's perfectly fine. In fact, it actually helps to increase the absorption if we give it with food. But we do want to administer either 2 hours before or 2 hours after any substance containing aluminum or magnesium. So I think about a lot of the antacids, like milk of magnesia, those sort of things, they have aluminum or magnesium in them, and they would actually reduce the rate of absorption of this antibiotic. Our other bacteriostatic inhibitors are clindamycin and linezolid. I just want to provide a brief kind of I wanted to create a brief little snapshot of clindamycin because I feel like you will see that one frequently in clinicals. The linezolid, also known as Zyvox, if you work in a critical care institution or in a long-term acute care place, you will see that medication given. It's a pretty big, bad antibiotic. Clindamycin, again, good for both positive and negative. It can be bactericidal if the organism is actually susceptible. Sometimes it's not. With this medication, again, we see some of those same side effects that we kind of see with every medication, antibiotic that we could possibly give. Aminoglycosides. I put the little death symbol on here just because I wanted you to understand that this medication, if it comes out, it's a big gun. This patient's really sick. We typically don't see these in our primary on our normal floors. We'll typically see them in a monitored unit, like a telemetry unit or a step down unit. This is one of those big bad drugs that when it comes out, Miss Hardy's got her phone out. I'm looking all through the drug book because I have got to update myself on that one because I don't give it very often. In fact, I think in my lifetime, I think I've given it twice. So again, when I see this medications come out of the locker room, I pay attention to them and I make sure that I am up and ready to give that medication by reading through my drug book on them. The aminoglycosides that we're most likely going to see in practice is gentamicin. We see gentamicin a lot in our NICUs and our newborn nurseries, and then, like I said, in our critical care units. This patient has to be watched closely. We want to make sure that we're giving it with adequate fluid replacement because this medication can be nephrotoxic. Here's a little slide here all about aminoglycosides. Again, ototoxic, nephrotoxic, and cause some hearing damage, can cause some kidney damage. These medications do have to be followed up with peaks and troughs because we want to make sure that the patient's not getting toxic on them. Again, it'll knock out your hearing, it'll knock out your kidneys. These medications you've got to be careful with. If not, we can hurt our patients permanently. Here's just another one of those slides again to help you with those levels of medications. The gentamicin is on here, and again, you can kind of just walk yourself through and you can see all the different levels on there. Fluoroquinolones. Again, another one of those medications who's going to interfere with the bacterial synthesis of the DNA, so that the bacteria, it can make itself, but it just really can't like do it right because it's just going to be all jacked up. Again, these medications came in droves and generations. We had first generations. The first generations were kind of duds and they're no longer effective, so they've been taken off the market. Don't worry, don't feel sorry for them. They'll come back. You know how all old things come back anew. They'll find a use for it. Don't worry about it. But some of these medications you're probably very familiar with. And in NP school, when I was going through school, one of the things that my professors taught me was that Cipro was for below the belt infections and Levaquin was really for above the belt infections. I will tell you that that plays out most of the time. You'll see that happen, but ciprofloxacin does have some direct actions against some of the respiratory things that Levaquin doesn't. They tend to want to reserve Levaquin for big bad things because it is so incredibly effective in what it does. So here's a little thing about Cipro. Cipro is kind of one of those fun medications too that can be given, you know, as a PO, IV, and it can also be given as eye drops and ear drops too. So you may see that as well. Are you? Yeah. Okay. Sorry, I had to hit pause. Took a phone call. Okay. So side effects of Cipro. Here they are. Weird things about the fluoroquinolones is that they can cause peripheral neuropathy, which is the burning, tingling, stinging in their extremities, their feet and their hands. And then the really weird thing is that we found, and it really was more after Levaquin came, or levofloxacin came out on the market, was this spontaneous tendon rupture. Like these old ladies were taking Levaquin for whatever was ailing them. And next thing you know, they're like, oh my God. And then they dropped over. And sure enough, they snapped their Achilles tendon like that. We found more incidents of tendon rupture in patients who were taking the fluoroquinolones and were taking a corticosteroid. So any patient who's over the age of 60 and taking a corticosteroid, no fluoroquinolones for you. Also too, because of this tendon rupture issue, at first when Cipro and Levaquin first came on the market, we were giving it to children less than 18. And then again, we were seeing this spontaneous tendon rupture. Like I said, most often the Achilles tendon. So not giving that to anybody anymore under the age of 18. This medication does process out through the renal system. So again, we're looking at BUN and creatinine. Two antacids don't mix together either 2 hours before or 4 hours after or 2 hours. We want to make sure that the patients have got adequate hydration. And like I said, these medications, the ciprofloxacin does come in otic or optic preparations. FYI, you can put an eye drop in the ear, but not an ear drop in the eye. So just put that in your pocket just in case you need it. Sulfonamides treat both gram-positive and gram-negative bacteria. You've got Pneumocystis carinii, Shigella, and urinary tract infections. These medications are all treated by our sulfonamides. The sulfonamides, what they do is they go up to the bacterial cellular wall and they look at it and they pick out the folic acid out of the wall, and then the wall just all kind of comes crumbling down. So go sulfonamides. Here's the names of your sulfonamides. Just kind of as an FYI, any patient who's allergic to a sulfa drug typically shouldn't take a thiazide, a loop diuretic, or any type of a sulfonylurea that's used for an oral diabetic agent, because you'll have some cross-referencing there. One other drug that I put on here is silvasulfidine, also known as Silvadene. This is a topical cream for burns. So the basis of it is basically like Noxzema, and then they put silver in it, which helps to prevent antimicrobial growth. The Silvadene should never be used on the face because it will begin to stain the facial skin a silver tone. So if you have a patient who has a severe burn, no silver Silvadene on the face. So before we give the medications, we need to know about a couple of things with these. Number one, these patients, absolutely, we never give it to anyone less than 2 months of age to avoid keratonictus. It's an eye thing that happens. The patient has to be able to consume enough water, usually between 15 to 2,000 mLs of water a day, to avoid something called crystalluria. If they take a sulfonate drug and they don't put enough water in it, it will get hard packed together and make crystals, and then the crystals then will like shred the urethra. So very important that the patient is able to drink enough water in order to make sure that the crystalluria does not happen. Usually between 15 to 2,000 mLs, 1,500 to 2,000 mLs of water is sufficient to prevent that from happening. Usually I just tell them it's going to be like glass coming out of their urinary system, and they're good. They're like, oh, I will definitely take care of that. It can also cause some blood abnormalities. Again, messes with their red blood cells for whatever reason. The only other symptom that we need to know about is about Stevens-Johnson syndrome. Okay, next slide. So Stevens-Johnson syndrome is a syndrome that happens whenever we give certain medication, and basically it starts up an autoimmune response in which the body actually begins to reject its own skin cells, and the patient will literally peel off their skin. It is like having a 3rd-degree burn. So this is a list of medications that can have Stevens-Johnson syndrome. One of the things that I always encourage you to do is to keep these little tidbits like this off to the side in your clinical notebook. If a patient begins to have any kind of a skin reaction with sulfa drugs, we immediately stop the medication, notify the provider, and get a change. There is a couple of other medications that just do not like to play with them, anyone. And again, I hope that you're kind of starting to see a list. Warfarin, phenytonin, theophylline, sulfa oral hypoglycemic medications. All of these medications tend to react poorly with their sulfa medications, and therefore they can cause a lot of toxicities. Whenever we give these medications, we always want to monitor their input and their output. At least 2,000 to 3,000 mLs of fluid per day. If you can get 15 to 2, I'm usually pretty happy. We don't give these sulfa medications to patients in their third trimesters, never with antibiotics, and then we always look for the cross sensitivities. The other medicines that fall into this weird kind of category all by themselves and don't really have another place in this world is our urinary antiseptic drugs. The one that I wanted to spotlight for you is called nitrofurantoin, also known as Macrolide. The primary goal of this medication is that it helps to treat bladder infections. And in our elderly patients or in our pregnant patients, it's a great option for them to help to prevent or to help to stop their bladder infection. This medication will be highly concentrated in the bladder, which is kind of a unique feature of the medication, that it really concentrates there. So with these medications, do need to make sure that they know that this can cause their urine to be really, really dark. And because of that dark urine, you just need to let them know. I mean, you don't want to go to the bathroom and be like, oh my God, there's something wrong, and then run to the emergency department when it was just a side effect of the medication. Metronidazole is another one of those medicines that I wanted to highlight for you here. We'll talk about it again when we talk about patients who have parasite infections. This medication can be used not only for parasites infections, it can also be used for, protozoal infections, but also for bacteria. So when you see it show up in someone who has a bacteria infection, you're not like, what? I thought that they needed to have like a protozoa or something like that. No, they use it in other things too. So I just wanted to kind of put that out there for you so that you kind of think about this one whenever we're giving different medication classifications. This medication, again, kind of the same side effects that we've seen with others. The weird thing about this one is that it can cause this metallic taste in their mouth, and then it can cause some of these neurological side effects. With this medication, we want to avoid in the first trimester. We know in animal studies it doesn't seem to do a bunch, but anything in the first trimester that we can avoid as that baby is developing is really important. No breastfeedings for 3 days after the last dose. So the mom's taking the medication, no breastfeeding, and then for 3 days after that, no breastfeeding. Absolutely, positively, please warn your patients that if they're taking metronidazole, no alcohol. They will have this horrible reaction to alcohol like you would not believe. They'll begin to throw up, they'll puke, it'll be horrible. So don't give this medication with any form of alcohol. Like I tell my patients to stay away from their mouthwash until they're done with this medication for 3 days. Again, we see some of the same players again showing up. They're like, don't want to play with anything. The warfarin, the phenetonium, the lithium, cyclosporin, these medications, if you don't know, you need to be looking up and cross-matching to make sure that these medications aren't going to cause any serious issues. Guys, I promise, the longer you do this, the easier it gets. So here's just a couple of review statements for you to kind of think through and kind of process and say to yourself, okay, can I answer these questions? I guarantee you they'll be important as we go through our study of antibiotics. So you're probably wondering what would happen to this guy right here. Well, based upon the guidelines and the things that he's talking about, and based upon the clinical guidelines, this patient would not be receiving an antibiotic today. I will tell you that the more that I've learned about antibiotics, the more that I've come to appreciate the fact of how many we prescribe, how many patients get prescribed antibiotics when they don't need them, and then just good symptom therapy and management. We have a ton of medications over the counter for this gentleman to help to control his symptoms, but the recommendation and the guidelines based upon what he's telling me would probably most likely be that he just needs some symptom management and he'll get over his flu or his cold in the next couple of days to weeks. Unfortunately, as Americans, we're not very patient with a lot of our medications that we have, and they're like, but they keep coming back. Right, you have to keep treating your symptoms, but the good news is that this guy's probably going to be okay without an antibiotic. So, all right, guys, we'll bring you guys some additional information about some more chapters here pretty soon.